sensitive. Okay, so basically this happens in fibroids. Once a woman has fibroid, okay, more blood supply goes to that fibroid. That is what will make it to just be enjoying itself and be growing bigger. So basically, this of course will starve the uterus, of the required blood supply. And of pregnancy is a continuous, it's a process that also requires similar blood supply and all the whatnots and hormones. And basically, there's already something that's diverting, that's what it needs to thrive. So basically, the result.
Hmm. So when a woman who is struggling to conceive comes to you, how do you determine like whether the fibroids actually the cause of infertility for her? Two ways, or how do you determine if it's the fibroids that's causing the miscarriage? Like in my case, I didn't have a miscarriage; it was treated. But there's some people who that happens. So my question is two throngs. How do you determine if the fibroids are what are causing the miscarriage? I suppose miscarriage is also a form of infertility now, Abby.
Well, yes, yeah, we can actually say that. But the thing there is that the woman is getting pregnant. She's just not sustaining the pregnancy. Yeah,
Sustaining.
yeah. So
Also,
it's just a
infertility
problem.
is
It's
that
just
you
a
don't get
problem of
pregnant.
sustain. Yeah, yeah, just a problem of sustenance. So
Okay, right. Okay, so two questions in one. When a woman comes to you, how do you ascertain that, or the cause of the miscarriages is the fibroids, and how do you ascertain as well that the fibroids are what is causing the infertility?
okay, thank you. So when the woman comes to the hospital, basically the woman has to be evaluated. So
Okay.
be whatever case she presents with, maybe having recurrent miscarriages or even outrightly not getting pregnant. So she has to be evaluated. First of all, there are a lot of things with respect to recurrent miscarriages. It's a discussion that is quite different. So basically, she will be assessed for genetic causes because we see that recurrent miscarriages, the cases that are caused by genetics. Okay, genetic, which are in this case now, genetics does not talk about familial problems, but we're talking about chromosomal anomalies.
Okay.
Okay, so basically, and then there are other conditions like the antiphospholipid syndrome, even diabetes and hypothyroidism are endocrine conditions. Okay, structural anomalies like uterine fibroids or uterine anomalies themselves. Okay, and so basically these are some of the things we might be looking out for. But for a woman who's trying to conceive, basically we would have to now evaluate her, evaluate the other organs, okay, or the other criteria that allows for a woman to get pregnant. Like for one, we have to do a sperm analysis. See, the conversation is now
Right.
changing. For the man, for a spouse,
Yeah.
yes, because sometimes even the difficulty in getting pregnant is actually attributed to male factor. We've seen that in almost 40 to 50% of the times. So you check the sperm, you check that the woman is actually ovulating. And how do we do this? We do this by doing ultrasound scans and also doing the hormone profile to check that the woman actually doesn't have any ovulation problem. Okay, the hormone profiles can also let us know whether this woman is ovulating. She has normal estrogen levels, progesterone, the FSH and the LH are within normal limits. That ovaries are sort of functioning properly. Okay, and of course, using even transvaginal ultrasound scan to check that the ovaries are of normal integrity. So basically, you want to do that. And then, of course, even the scans themselves, you repeat the scan, you do scans to check the womb itself. You want to check for the presence of fibroids. You want to do sonohysterography to check whether there are presence of inside of the endometrium, or even for some people, they might do hysteroscopy, okay, to check whether there's a fibroid inside of the womb, or if there's a polyp inside, or even adhesions, okay. The discussion is just going to take a lot more angle to it. You understand? So, but basically, investigations will be done for the ones after you've excluded all these other elements. The sperm is normal, hormone profile is normal, no adhesions inside of the womb. Then, if you see a fibroid in there, and the woman has been fulfilling all the necessary of pregnant, meeting as at when necessary on our day or in better window, okay. And then, of course, the sperm is okay, she's ovulating. But then you're not seeing a large size fibroid, okay, impinging on the endometrium, or you did hysteroscopy and you found a fibroid inside of the womb. Of course, that is definitely the reason the woman is pregnant. So to digress a little bit. Sometime in 2021, I saw a lady who has been finding it difficult. I mean, she has a child, but she wasn't, she, after that child, okay, she started trying again when it was time for them to start trying again, but then she didn't get pregnant. She even did IVS after, like two IVS. And so when I saw her, I told her, I said, you should go for hysteroscopy. She went for hysteroscopy and found the fibroid inside of the womb. She took it out. She now repeated the idea because she was already of age. I think she was, at that time, she was like 43 or so. So she repeated, yes, and she got pregnant. In fact, till today, if you see her, she would remind you of me. Yes, because for some reason, I just felt like, just look for it. Been trying for a while, even naturally, you're not getting pregnant. She was like, no doctor has ever told her that there could be something inside of the womb. And she's done IVF twice. Well, that's a discussion for another day. So any which way, she did the procedure, she did the hysteroscopy, saw the fibroids, removed it, she did the IVF and got pregnant. Today she has twins. And she will tell you anywhere. In fact, I've never seen this woman. It was just somebody during a program like this that, you know, on one of our IG live. So she just sent a message there, answered the question, and then she went and just, you know, engaged all my advices, and then of course she got pregnant. So basically, these are some of these things.
Wow. Wow. Well, I mean, shout out to great doctors, because this is even way away from the conversation, because it was during that hospital episode I went for, and I got treated, that the CMD of the doctor I was at just randomly said, oh, I want to check you again, checks me and finds out that my cervix was open. So we had to do a cerclage for me. So so every time I see my daughter, I remember how much of a miracle she is, and I'm always so grateful for, I think her name, Dr. Ademi, I think that's her name, because if she did not ask for another examination, because by all counts, by all means, they were about to discharge me. She just said, oh, I want to check you, took me to the theater, the speculum, clinical, checked, and was like, then asked me to do a scan, asked me to do another scan, called in somebody, like a senior colleague, to come check me, and then discovered that, oh, my cervix was short, it was incompetent, the cerclage was. I remember feeling so scared. I was like, Ebami, it's stomach ache that I can't. I'm currently pregnant. What's all this? So yeah, thank you again. I'm saying thank you to you on behalf of, you know, the woman, because it's very, very, it's such a blessing to have doctors who go over and beyond, you know, for their patients. So thank you. I'm saying thank you to her. My next question would be, you mentioned the woman has to be examined. So what's the English? What's the process of examination, like diagnostic tests? Yeah, what are the tests that you do to check? You mentioned hysteroscopy. Yeah.
Okay. Yes.
But what are the other tests that you can do to ascertain that, look, beyond every shadow of doubt, this person has fibroid?
All right. Okay. So basically, some of the tests that are done for a woman when evaluating her whether she has uterine fibroids, they include the transvaginal ultrasound. Okay. Yeah, so basically we'll do the transvaginal ultrasound scan, or even just the regular pelvic scan. For people who do not have access to the transvaginal ultrasound scan, they can actually do the pelvic scan. That should be able to still identify fibroids and all. Okay, so basically transvaginal or pelvic ultrasound scan, that's number one. Number two, so hysteroscopy. Hysteroscopy cannot be ruled out. That is used to diagnose fibroids that are actually inside of the uterus. So these are called the submucous fibroids. The ones that I said are very notorious to cause miscarriages, heavy bleeding, and all the problems that these fibroids will present with. Particularly the hysteroscopy. For some other persons, they might need to even do, what do you call it now? Okay, so usually some persons, they might need to do a biopsy. Usually this is done to just rule out whether the fibroid is cancerous or not, especially when you're seeing that the fibroid is growing in the woman who is already postmenopausal, one that has stopped seeing menses. For some persons, I need laparoscopy. Okay, laparoscopy to diagnose. Laparoscopy is like hysteroscopy. They involve the use of small cameras that are passed into either the uterus or into the tummy. But for laparoscopy, you're passing it into the pelvic cavity from the tummy. Okay, so it's as if you're looking usually used to diagnose fibroids that are outside the uterus, not the ones inside. Okay, that
Yeah.
are the subserous fibroids. Okay, so basically you can also do that. For some people, they can go the extra mile to do a CAT scan and all the whatnots. But the common tests that are usually used to diagnose uterine fibroids around our vicinity and in this part of the world, easily the hysteroscopy, laparoscopy, and the transvaginal ultrasound scan. Okay, so usually the endometrial biopsy is only used to rule out malignancy after you have removed the fibroid. Okay, yes, so basically that is for diagnosis. But we also need to know that when woman, okay, this is now talking about some of the symptoms generally. So because it's also part of the diagnosis, you have to use the symptoms too. When a woman comes to even without doing tests, the moment you see the woman complain of very painful menses, heavy bleeding, bleeding in between menses. Okay, when we say bleeding between menses, meaning she just sees that meaning she's maybe 1 week down the line, she's seeing another blood again or spottings here and there. These are what we call intermenstrual bleeding. So basically, all of that will be present. Pelvic pain, woman having constant pelvic pain, even painful intercourse, okay, the size of the fibroid that she has, or she has to experience abdominal swelling where she touches her tummy, she feels a very hard mass on one side, or maybe even could even be the husband telling me that I just noticed that my wife is having there's one hard thing on one corner of her tummy there. Of course, these are now things that will now prompt that suspicion of the woman fibroid that will warrant other investigations, both physical, cause diagnosis, using image.
Hi, Dr.
Like all the
Collins.
other ones I just listed. Okay, and then for some other persons, they might even start to experience what we call pressing symptoms. So, yes, can you hear me?
Yeah, it was breaking a little
Can you
bit.
hear
Yes,
me?
yes, I
Can
can
you
hear
hear
you.
me now?
Yes, yes. Hi, Dr. Collins.
But, okay, all right, thank you. Yes, I can hear you.
Yeah. Okay, can you hear me now? I can hear you, but can you
Yes,
hear
I
me?
can hear you. Okay.
Okay.
Yes, I
All
can. I
right.
can hear you. Is it
Okay.
better now?
All
Is
right.
it better now? Okay.
Oh, yeah.
All right.
Yeah, it's better.
So
Yes.
yes, so I was saying that we can also use the symptomatics. Okay, so the symptoms that the woman experiences in diagnosing even the presence of uterine fibroids. So they give a very high level of suspicion that will warrant all the other investigations that I said. Symptoms like heavy bleeding, painful menses, okay, and then what we call intermenstrual bleeding. So intermenstrual bleeding simply means when the woman finishes her menses, she still stays some spottings maybe a week or 2 weeks after, things like that. So that's bleeding in between menses. That is called intermenstrual bleeding. And then for some other persons, they can experience painful intercourse, the presence of a mass, abdominal mass that is palpable, that can be felt even by the spouse or even by herself. Okay. And then, of course, some persons might experience what we call pressing symptoms. Pressing symptoms because of the location of the fibroid. So a fibroid that is located outside and growing very, very large will compress on surrounding structures. Can compress on the bladder at the back, at the front, or the intestine at the back. So it can result in constipation and, of course, even frequency. Frequency simply means that urge to want to always, you don't even drink any small thing, water, you not drink small water, you want to go and urinate. So basically, that's frequency.
Okay. Okay. You spoke about the woman who had nobody knew she had the fibroid until she had met you. So in that case, you said she removed the fibroid. So the only way for her to have conceived was if the fibroid was removed. It wasn't a case of the fibroid could coexist with the baby, right?
Yes, that wasn't a case of the fibroid coexisting with any even conception at all. Yes, so it has been preventing the conception. Yes, and because of the location, being that it was a very small uterine fibroid located inside of the womb, these fibroids are called submucous fibroids inside the womb. Okay, because it's a small one, which was only visible, during the hysteroscopy, so that's the reason why she's not been able to conceive. So it was just strategically located at the point where an embryo is supposed to implant, and then it was removed. And yeah.
Oh, so how long can a woman wait after the fibroid surgery before she can conceive?
Okay, so generally a woman is expected to wait for 3 to 6 months. Okay, most times we do 3 months. Yes, 3 months. But extensive, if the fibroids or the surgery was very extensive, usually see now. Let me just explain. Let me just digress a little bit, just to give this a little bit of expression. So I've seen a woman who, when I did scans for her, she had just, from what the scan could pick, because it was quite a very bulky uterus. Usually, this is the language we use when we see that the uterus is reading with fibroids. A lot of them. So I was able to count maybe about 4 or 5 large ones. When we say large fibroids, we're talking about fibroids that are above 50 millimeters or 5 centimeters. Okay, and then she has some small ones around there that I could say maybe in total, maybe she had 7. Okay, but when she went for surgery, 62 fibroid nodules were removed from her. I meant, yes, I didn't put water in my mouth. Let me just, for want of words, 62 fibroids were removed from her. So you can see that limitation of even the scans relative to when you're doing operation and then you're seeing what you're seeing as you're removing the 62 fibroid nodules. Yeah. So with this said, such a woman, you don't expect such a woman to just immediately go and start conceiving 3 months after. You have to give her enough time, because that operation was quite extensive, removing a lot of nodules from the uterus. So relative to somebody who maybe 1 or 2 fibroid nodules, were removed from the uterus. So usually the time frame will be subjective to the recovery process, and all of the time frame that you give to the woman. So subject to the recovery process, how soon she recovers, how soon she regains her reproductive potential and all the whatnots. So basically, that is what it's on. But the time frame that is given generally is 3 to 6 months. After the surgery, the woman should be ready for conception. Yes.
What about for women who have fibroids and still have a baby? They have fibroids and the baby growing together, they're coexisting. And is there anything that the woman is supposed to do? Actually, or how do you ascertain that, this fibroid, we don't need to remove it because she's already pregnant and there's a fibroid there? How do you manage that situation?
Okay, beautiful. So basically, there are certain things we use to determine whether a fibroid can be problematic or can cause problems. Okay, the size and the location of the fibroid. So in all honesty, location matters more than size. The reason is because you can find a fibroid that is strategically located. So basically, just impinging on the endometrium. So I keep using that word, pressing on that space where the baby is supposed to stay, even though it is located outside. Such a fibroid will be problematic, will cause problems, and such a fibroid should be removed. But you might find a tiny fibroid like this now, that is just located, even though multiple on the uterus, they won't pose any threat, especially when the sizes are less than 50 centimeters, like we said. So usually fibroids become a lot more problematic, when they are strategically located, maybe impinging on the endometrium or located inside of the womb. Okay, yes. But and then again, when the size of the fibroid is less than 50 millimeters and it's just, even though multiple, some people are still able to conceive. Yes, we have a lot of people who even currently have children, not a child, children. And then they have their fibroid in there and they've never bothered removing it. Yes. So basically, these are some of the things. You use that size and the location criteria to determine whether a fibroid should be removed. Yes, for again, just to reiterate, for a fibroid that is impinging on the endometrium, such a fibroid must be removed because that poses a threat to the sustenance of any pregnancy or can even accurately prevent pregnancy.
Sorry, carry on. I'm busted to ask this question, but have you seen any woman who's been pregnant at the same time as having the fibroid pressing on the endometrium?
Well, truthfully, I think I have.
Well, in the womb, you mentioned
endometrium. Or in the womb. Yeah. Good. Yes. So again, like I said earlier, at the beginning of this discussion, I was like, even the submucous fibroid, but I hate to really say it on the program because some people will now be like, but there is a doctor that said that even though I have it inside I can still get pregnant. No, it is not a one size. Yes, it's not a one size fits all. So basically, the endometrium is like a cavity that looks like this, okay? So there are certain places that are called strategic locations for embryo implantation. So if you're having a low-lying submucous fibroid, chances are excellent such a fibroid will not even do it. As a matter of fact, just last year, there was a client who was supposed to do surgery, but well, for some reason, after evaluation here and there, she decided to be like, no, I'm not doing anything. Let's go ahead with the IVF. We transferred the embryos and the woman got pregnant. Yes, he has her triplets. Yes, as I'm speaking to you. So you can see So basically, it's not all submucous fibroids that would really prevent pregnancy because of the
Right.
location of the submucous fibroids. Submucous fibroids, again, are fibroids that grow inside of the uterus. Okay, but then normally, once a woman has submucous fibroids, it is expected that she removes it because chances are excellent. Submucous fibroids almost always prevent pregnancy. Okay.
Pregnancy.
Yes. Oh, yes, they do. They
So it's
prevent pregnancy.
impossible. So what you're saying is like, so this case is a minority. So typically,
Yes.
normally what happens is you can't get pregnant if the fibroid is there. Is
Okay.
in
Yes.
the
Typically,
endometrium
inside. Oh, yes. Typically, yes, yes. The woman will not get pregnant.
will
Yes.
not get
Typically.
pregnant.
Typically,
Okay,
yes. Yes, but then of course you see people with fibroids outside of the uterus getting pregnant. Yes, I mean outside of the uterus,
outside of the uterus.
outside, or even in the muscle of the uterus, like the ones that are called intramural. The subserous fibroids are the ones that are called harmless fibroids. They are the ones that are just attached to the uterus like a different component, maybe on top of the uterus. These fibroids, they are mostly harmless, mostly harmless. Yes, they
Right.
won't even disturb conception. But the intramural ones can be the ones that can now become problematic, or even the submucous one.
Right. Finally, before we go, because this has been such an educative session. Before we go, this question is because of what the woman who had the IVF and the fibroids. So obviously, even if you have fibroids, you can still have babies via IVF.
Oh yes, yes. Even if you have fibroids, you can still have babies via IVF or any other fertility treatment, especially after the IVF, after the fibroid has been evaluated and found not to be posing any threat to conception,
Mm-hmm.
okay, or even to the sustenance of the baby or sustenance of pregnancy.
Wow. Okay. Thank you so much, Dr. Collins, for today's uh amazing today's amazing session on fibroids and fertility. I was very because sometimes you just think about these fibroids and it's such an evil, for me it's evil, right? Because and I've seen there are women who have passed on from fibroid surgeries, right?
Yes, yes. Truthfully, so the thing also it also depends on the number of times a woman has had the fibroid surgeries. Not
Hmm.
all. See, yes, we know. Yes, it is bread and butter. Truthfully, there are certain things we call bread and butter kind of surgeries in Nigeria. Okay, because it is something that we find very common around us. So basically, almost everyone does fibroid removal surgeries 2 times, 3 times. But then it gets to a particular time where the woman must have had multiple fibroid removal surgeries where she's counseled against having a repeat surgery. So oh
Uh,
yes, because sometimes there could be adhesions that will form, not even there will definitely be adhesions that would have been formed inside of the uterus and make the surgery, a repeat myomectomy, very, very dangerous. So
hmm.
usually for some of these women, you have to talk about other modalities like using injections, for treatment to shrink the
I
fibroids,
was
and
gonna
then
ask that.
yes,
Oh, so
and yes.
it is possible for the fibroids to shrink.
Oh, it is possible for the fibroids to shrink. Yes, it is possible for the fibroids to shrink. But the only problem with this is that once the injection is stopped, okay, and the woman starts seeing menses again, okay, the
Oh,
fibroids will continue to grow. Yes,
sorry. When she's doing the injection, do her menses stop? Is that what you're saying?
yes, it will stop. It will stop.
How does she give birth?
Yeah, so exactly. So that's the thing. So usually you only use this as a form of treatment for women who are still desirous of conception, okay? But and as don't and more like they are advanced to having open surgeries, or
Surgery.
maybe there's a contraindication for them to have a repeat myomectomy. So what you do, you give them this injection to shrink the fibroids to a point where you're not comfortable to do fertility treatment for them, to do IVF, okay, or so. So, and then of course, once that period, usually they take the injection for around 3 months, for some people even up to 6 months, to shrink the fibroids very well. But the only problem with this is that once you shrink the fibroid, the uterus also shrinks. So the moment you start the fertility treatment, okay, the medications, the hormonal preparations you're giving to the woman will cause the fibroids to start growing again. So well, the idea is just to do it in such a way that you see the woman will still be able to conceive, and then at least at the end of the day, not having to do surgery. Okay,
Ugh.
so that's the idea behind this, and it's a non-invasive treatment for fibroids. There are even other treatments like the HIFU where you use ultrasound to try to shrink fibroids. The only problem with all of these treatments is that they do not give a sustainable result. The only sustainable result you get is when you do the open myomectomy, or you do the stereoscopic myomectomy, or even the laparoscopic myomectomy. So the myomectomy is the one that will give a lasting result. But using the HIFU, using what do you call it now, the gonadotropin releasing hormone agonist, Zoladex or Leuprolide and the whatnot. Basically, this would only shrink the fibroids. Once you are done, once you remove the medications, it starts to grow again. And of course, for other people who have fibroids and are experiencing pain, there are medications, ibuprofen and the whatnots that can be used to, of course, reduce pain and just to allow them, and even some medications like tranexamic acid and mefenamic acid, basically are medications that would help to control pain and bleeding. Okay.
Okay, thank you, Dr. Collins, for today's free consultation. We truly appreciate you. Dr. Collins is an assistant medical director at St. Ives, medical director and fertility physician. You can see that because every time he comes, he talks about women, female fertility, and everything. And you can tell he's very, 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 very passionate. This is his area of specialty at St. Ives Specialist Hospital in Abeokuta. If you want to get in touch with him, you can do so using the TeleDoc app. Thank you so much, Dr. Collins. Let me let you go before I continue. Thank you so much for today's session of Radio Doctor. We truly appreciate you. See you next time for Radio Doctor.
All right. It's always a pleasure to be on the program. Thank you. Bye-bye.
Right. Bye. Radio Doctor Women Radio WFM is Nigeria's first free consultation, specialized radio health program, broadcast Mondays through Fridays at 10 a.m. You want to join us tomorrow for another edition of Radio Doctor. Many thanks to Aisha Sani, the producer. Many thanks to those in the studio, Benjamin, Rachel, I think, and the executive producer, Tom Okewale Shonaya. My name is Fumi Bangwala. Do have a healthy day. Bye for now.